So good evening everyone and welcome to tonight's second and final webinar with National Centre Series, Practical Application of Mandatory Reporting for Child Sexual Abuse. We are joined tonight by speakers Dr. May Sue, Stacey Ullman and Rachel Neal. My name is Jovi and I'm the Education Events Officer for the Specific Interest here at the RACGP. I would like to take the opportunity to thank our partner, the National Centre. The National Centre for Action on Child Sexual Abuse is a symbol of hope and an essential vehicle for action for many victims and survivors of child sexual abuse. Founded in late 2021, the National Centre is a partnership between three respected organisations with strong histories of leadership and responding to child sexual abuse: the Australian Childhood Foundation, Blue Knot Foundation and the Healing Foundation. The establishment of the National Centre is to raise awareness and understanding of child sexual abuse, support help seeking and guide best practice was a key recommendation of the 2017 Royal Commission into Institutional Responses to Child Sexual Abuse. I would like to now hand over to Stacey, who will go do the acknowledgement of country. Over to you, Stacey.
Thanks, Joby. Before we get started this evening, I'd really like to acknowledge the traditional custodians of the land and sea in which we work and live, and pay our respects to elders past and present, and that extends across all the lands in which you are all joining us from today. I'd like to also acknowledge any Aboriginal and Torres Strait Islander colleagues in the room today who have joined us online. We also seek to honour the lived and living expertise of all victims and survivors of child sexual abuse across all ages, cultures, abilities and backgrounds, and commit to substantially addressing the harm of child sexual abuse now and well into the future. We also recognise that there are children and young people today who are experiencing child sexual abuse and dedicate ourselves to doing all that we can to expedite and promote their effective protection and care.
I'd also like to recognise that there might be some participants who are listening to this webinar who might have their own experiences that might impact on what we engage and with what we talk about today. If you do need to reach out to any of the speakers here today, please just let us know. If you need to drop out, we completely understand.
We also have a handout that is available for you after this webinar with a list of different support services. So we do acknowledge that this can be difficult content to engage with. And if things come up for you, whether it's during the webinar or following or in the days or weeks after, we absolutely encourage you to please reach out to those supports.
So some of you probably already know who I am. My name is May. I am the Chair of the RACGP Specific Interest Group Abuse and Violence for Families. I actually continue to work part-time academically, and I'm a GP supervisor, and I have interest in mental health, complexity, abuse and violence and neurodiversity. Currently completing my PhD in abuse and violence at the Translational Health Research Institute of Western Sydney. And I'd like to also introduce my co-presenters. Stacey, who you've heard speak already. So Stacey is an accredited social worker with over 16 years of experience in child protection, family and sexual violence, practice and training. She's the manager of practice development and training at the National Centre of Child Action Against Child Sexual Abuse and has been the project lead for the Strengthening Primary Care Responses project, which commenced in 2023. We're really fortunate to have Stacey's expertise with us today. Rachel Neal is the Executive Director, Integrated Practice of Knowmore Legal Service, based in the Brisbane office. And Rachel's worked at Knowmore since November 2019 in the community legal sector for many years in various roles. She has spent her legal career committed to helping vulnerable people to access their rights within a strong framework of trauma-informed and multidisciplinary practice. And we're even reflecting just before we joined today just how valuable it is having the perspectives of the different disciplines of Stacey and Rachel to join us together with the RACGP. So thank you very much for being here. So by the end of today or tonight, we're hoping that you will feel like you can recognise and respond to child sexual abuse using the National Centre for Action Against Child Sexual Abuse resources and outline mandatory reporting obligations across different jurisdictions in Australia. This webinar was actually developed as part 2 of a previous webinar that we co-developed and delivered earlier in the year. And as part of that webinar, we really wanted to reach out and ask participants what sort of things that they were interested in finding out next. And this really came out as area that participants were really interested about. It wasn't just about knowing what were the mandatory reporting requirements. Participants really wanted to know, what does that mean in practice? How do we actually act on this? So we're hoping that for today, this is what we're going to be able to address and talk about. And there is going to be a Q&A option. So we would like and welcome for participants to be able to reach out because this is for hopefully what is addressing your learning needs. To start with, it may be helpful for us just to have a bit of an idea of where those of you listening in today stand in the context of that. So if you can respond, there's 5 different options here, going from not at all confident to extremely confident, just to get a little bit of an idea about where we might be pitching some of our discussion here tonight. I'll just give a couple of minutes just to respond to that. It's actually really interesting because we discussed just before where a lot of people who are listening in tonight may be placed in terms of this. So it's really great to see that those of you who are in the room, you know, might be, most of you might be at least have some confidence in terms of working in this space. So we may be speaking to a more experienced cohort, but that doesn't mean that some of you who are not at all confident, hopefully this still answers some of your questions. And so there might hopefully be a range from people who might be feeling less confident to very confident about what we might be addressing. On that note, we've got another question which is coming your way. This is through Slido. So if you have access to, I think we're all familiar with what QR codes look like, but if you have access to that, then we're just going to see how your responses come up here. I think there is a bit of a theme here about what participants might want out of what resources might support them. I mean, it really sounds like actually more clear-cut sort of guidelines or education. But I am hearing that having some process of an access to a regular sort of advice or regular sort of processes might also be helpful as well. And yes, I do empathise with the structural processes of less time-consuming access. I do need to probably put in perspective that in terms of the organisations that are represented here today, in terms of, you know, the RACGP and the National Centre for Action Against Child Sexual Abuse and Knowmore, our roles might be fitting more in terms of the discussions and the advice and the education. I mean, I might be biased in saying I'm all for advocacy, but in terms of some of those structural processes might be an advocacy piece. All right. If there's any other questions, then really happy for you to put them in the Q&A. But Stacey, I might hand back to you now.
Thank you. As was mentioned earlier, we do welcome Q&As throughout the session tonight. So if you do have questions along the way, please feel very free to pop them in the Q&A and we'll get to them as soon as we can. And there's time at the end if we don't get to them. For this evening, we have 2 different case studies that we will work through, and I will read these out just so we can make sure we meet the needs of everyone across different learning modalities. So you've recently relocated to a rural area, you're working part-time, and there is only one other general practitioner servicing the area. Many of the families are well connected, have long-standing relationships with medical staff, and have accessed the clinic across generations. In your 3rd week, you meet Sadie. Sadie is 14 years old and she attends the clinic alone. She asked for a prescription for the contraceptive pill due to concerns of becoming pregnant. During the conversation, Sadie discloses that she has a 22-year-old friend with who she's staying with, and that's due to being kicked out of home. She discloses there have been 2 occasions where he has come into her room and done things to her without providing significant information following that. Sadie asks you not to say anything to anyone about it as she doesn't have anywhere else to stay and doesn't want to get into trouble. So, Rachel, if we look at this case study in a legal sense, what do we need to consider when we're responding?
So, Stacey, I think we'd start with taking a close look at what's been disclosed to see whether it reaches the threshold of what might need to be reported under the mandatory reporting laws. So when I'm talking about this, I'm really assuming a level of knowledge from our previous webinar about what happens with mandatory reporting. We'll do little recaps as I go, but there are resources about the difference in the laws in each jurisdiction that came out of that first webinar that is available. And so when I talk about jurisdictional differences, that's where you can find those jurisdictional differences. So we need to work out whether this triggers a mandatory reporting obligation. We know that sexual abuse is a form of child abuse, risk to children that has to be reported in all jurisdictions. So there's no jurisdictional difference with that. The threshold will be whether you can form a reasonable belief or suspicion that sexual abuse has happened or that there's a risk of that happening. Now, the specific wording of that, it varies from state to state, but that reasonable belief threshold is consistent, and that's what you're always going to be looking at. So Sadie hasn't spelled out to you exactly what has happened here. She said that he has done things to her when he comes into her room. Ideally, you would ask further questions about what she means by that phrase. But if she's not more forthcoming about that, then you need to work with the information at hand that we've got in front of us here. I think it's reasonable to conclude that with the combination of that statement about him coming into the room and doing things to her and her wanting the pill to avoid pregnancy, there's a strong suggestion there that sexual contact has occurred and that sexual abuse has happened here. So I think that this does reach that threshold. But that's sort of not the end of the decision-making process or your thought processes here. Once you've reached that conclusion, yes, it's the type of abuse and that's at the threshold, you would want to look at whether there's any exceptions to reporting that apply. Now, just to recap, there are in each jurisdiction, and some of them are different to others, there are some broad exceptions, broad categories of exceptions, which fall into, and I'll go through them and look at whether they apply here. Whether it's already been reported to authorities, whether it's child safety authorities or police, that's not applicable here because it's clear that she hasn't told anyone. Secondly, another exception is that it's not safe for the child or another person for it to be reported. This is only present in some jurisdictions, but in any case, from what's before us now, there's nothing to indicate that it's applicable here and that there's any real risk to Sadie, except perhaps that she may end up having to leave that accommodation, but not enough to trigger that exception. Or thirdly, that the person abused, Sadie in this, is an adult when the disclosure is made and they don't want it to be reported. So that's something that will come up a lot when people are talking about, I guess, historical child abuse, but that's definitely not applicable here. The only other thing I would be looking at here is that given that Sadie's a teenager and the friend she's living with is also a fairly young person, I'd be having a look at issues of the age of consent and also whether what's called the close age defence might apply here. So this is a circumstance in the law, the age of consent laws, that's intended to cover consensual sexual activity between young people who are under the age of consent. And it sets out circumstances where it wouldn't be an offence. So in various jurisdictions, it'll be about the age difference between the two young people, and that is 2 to 5 years, depending on the jurisdiction. So if you've got two young people, even if one of them is over 18, but that age difference is within the range in the jurisdiction, then it may not be seen as child abuse. It will be seen as consensual sexual activity. Another exception under this would be that they're both under the age of consent, which doesn't apply here, or that the person believed that the child was over the age of consent. Now, the age of consent in all jurisdictions is either 16 or 17, depending on where you are. So at 14, Sadie's clearly underage. She's under the age of consent. But the age difference here is 8 years. So it's well outside of any of those close age defences. And we don't have any information on whether the abuser thought that she was older and over the age of consent. And you wouldn't be making further inquiries about that to see whether it fits here. So we don't have any close age defence here. But I guess I just wanted to take another step further from there to say that even if you did have a close age defence, so let's say that the abuser fitted within that 5-year time gap, if you're in that particular jurisdiction, it's all of that close age defence is predicated on the fact that the sexual activity is consensual. So it doesn't apply at all if it's non-consensual sexual assault, basically. And I think there are real red flags here. It doesn't seem to me that Sadie has consented to this sexual contact. She talks about being a very passive person in it, but also she's saying she's got nowhere to go and that she wants to keep it a secret because of that. So that suggests to me that even if he said that she was appearing to consent, I think it's a reasonable conclusion that consent wasn't freely given. And that's our definition of that. So we've got basically no exceptions to reporting here. You do have a obligation to report. We know that GPs are mandatory reporters in all jurisdictions, whether it's under the criminal law as members of the public or under the child protection framework as medical practitioners. So having worked through those legal requirements, I think that you are required to make a report, and you'd be making that to either the police or child protection authorities.
Thanks, Rachel. And May, what does this scenario bring up for a sole general practitioner?
First of all, I think just take a deep breath. I appreciate that for those of you sitting in the audience and in the room. This is not going to be an easy consultation, and there's going to be a lot of emotions which are going to arise being confronted with this situation as well. I think the situation that's happening here, though, for Sadie is that I think we can all agree that there are some serious safety concerns. Sadie's 14, she's vulnerable. She feels she has no other options for safe housing. And it's seeming very apparent and thank you, Rachel, for talking us through actually the process of determining that this is really something that we are going to have to report. And whilst there can be jurisdictional differences in different states for some scenarios, in this situation, I think it's probably going to be universal nationally that this is going to be something which we're going to have to report in this situation. So I think we do need to be upfront about that with Sadie, but I think it's also really important to recognise that that doesn't mean that it has to be an antagonistic conversation. And we also really need to reassure Sadie that Sadie is not the person in trouble. The big concern is going to be ensuring Sadie has options for a safer living environment. How child protection may respond may be different in different regional areas about how they respond to this. But I think you also have to remember that we discussed this in our previous webinar. The process of us actually reporting does not necessarily mean that, you know, police are going to come in with bells and sirens blaring and she's going to be dramatically removed from that situation. In most circumstances, child protection and a report to child protection is about information gathering. So we do need to put that in perspective. And if there is a serious concern about the process of how Sadie is supported in that process, that would also be part of what we are trying to work out in our consultation about how to support Sadie in the process of how that conversation goes with her and with child protection, to make sure that this is as supported as possible in that process. Certainly in the circumstances that I've worked with, sometimes we'd have conversations about funding for alternative accommodation options. You may also want to have a discussion with Sadie about access to DV services and housing. 1800-RESPECT is a national phone line support that you could contact with Sadie, or Sadie could contact privately as well if she wants some additional support when she's not in consultation with you. And you also do need to bear in mind that Sadie may still choose not to take up any of these options at the moment. So I also do need to bear in mind, we don't know the events that led to Sadie no longer living at home. So it may be that there's safety concerns about this living situation, but there might also be safety concerns about the living situation that Sadie left in the first place. So, you know, part of the conversation is going to be talking through all of those options. And yes, it's going to include housing, but it also might include what other supports are in Sadie's life, schools, peers, what other strengths that Sadie might have. We will need to have a conversation about contraception and sexual safety, and also sexual consent as well as other forms of abuse such as coercion, financial control, and also through mediums such as technology as well. Sadie may need to know that she is able to access Medicare, that she might need assistance to arrange a separate card alongside any other identity documents. In some situations, sometimes people leave their home situation and they don't have any forms of identification, which might be a barrier to them accessing care. So there are going to be logistics about, you know, how we have address all of these issues. It may be that you don't address all of this in one session. You may want to flag with reception that you might need to reshuffle appointments to enable time to have that initial conversation with Sadie. And there are various ways to do this. I schedule breaks in my appointment book to allow for unexpected occurrences. And sometimes I reshuffle appointments, and it might be that there's only 1 or 2 appointments scheduled after Sadie before lunch, which, you know, might be quicker appointments. So Sadie could be open to maybe reading material on contraception options while you attend to those appointments, which allows you to be less time pressured when you actually have this conversation with Sadie. So in the initial discussion, you know, the priority is really making sure that Sadie is immediately safe, you know, validating that what occurred to her isn't okay. And it may include some safety planning discussions, particularly in the context does she potentially have to leave her current accommodation in an urgent situation if she, you know, the conversation that you have with her might actually trigger her wanting to be able to say she's not okay with some of the behaviours, which may necessitate that she might not be comfortable staying where she is. So some of those conversations may be important to have early on. And in my immediate risk assessment, I also check on mental wellbeing and suicidality, as well as behaviours that might put other people at harm as well. You may need to check about emergency contraception as well as STI screening. And depending on the context and the timing, she might also choose to have a formalised sexual assault assessment. I'm going to bring us back to the fact that you're also working in an area where there are limited other practitioners. There's only one other general practitioner servicing the area. So it may be that you may have care only for Sadie, or you might know both parties as well as their family. So that might add some additional complexity on how you navigate and manage that. And it may be that there may be intergenerational trauma that we're now seeing play out in Sadie's situation. The 22-year-old who was living with Sadie and you know, their family or Sadie's own family might need support for their own needs, also to be able to make sure Sadie's safe. And that may be also one of the conversations with child protection. Sometimes child protection can offer supports to the family members to help keep the child safe as well. If there are multiple parties who attend the practice and there are ongoing safety concerns, you might need to coordinate and discuss with your practice manager and reception how you manage the appointments and make sure that they're not having appointments at the same time. And we do need to be conscious that some of you, I mean, I noticed that some of you in the room had indicated that you have some competence, so you may also have some additional specialised skills. So, you know, some of you might provide counselling or psychotherapy, or you may have other access to resources that, you know, not all other GPs have. So I just need to be conscious that the discussion about whether you hold care for multiple parties can be a very contentious one. So just to be really cautious if you are attempting that. And you do need to be really conscious and aware about the risk that that poses in terms of potentially colluding with one or another party. Also, in regards to access to care and counselling, SADI would be eligible to access victim services, which may vary state by state, but it might assist with financial assistance in an emergency, particularly if she has to leave her situation or accommodation, and counselling. And if you're the GP involved and this may end up as a matter for legal processes of the courts. So you may also need to consider how you are documenting in your notes, just to make sure that it's as objective as possible and as thorough and complete as possible as well. If you do feel like you need support through this, that was actually one of the comments that came up in the word cloud about what things would be helpful. I'm going to put a plug up for the GP RACGP Specific Interest Group, Abuse and Violence. We certainly do have regular sort of discussions of ongoing training, but also the conversations, and we can certainly have discussions as well about peer support or processes of professional supervision as well.
Thanks, May, and thanks to those that have asked questions throughout the case study. If you have any more, I might give you like 10 seconds to add them in now before we move to the next case study. But if not, we can always come back to them later. No, that's okay. We might move to case study 2.
Do you mind, Stacey, if I might make a comment to some of those questions?
Of course, of course. Yep.
So the issue about confidentiality is a really important one for general practitioners when they're working with families. It's really important that if you are privy to information from SADI, that any of that information you do need to consider at the age of 14 whether SADI is competent to be able to have the decision-making processes with it. I mean, the main situation might be in severe intellectual disability, and you actually don't feel SADI may have, like, you have to assess skill at competency, essentially. But let's assume that SADI actually does have competency in decision-making, and even in a situation where a 14-year-old does need assistance with these processes, there also is the assumption that you do want to ensure that they have autonomy in as much as is possible for their capacity level as well. So that means, from a confidentiality point of view, unless there is a real risk in terms of safety, the information that SADI does provide you is confidential, except in the circumstance that we have now identified from a mandatory reporting point of view that we do need to report this. Now, my stance on this, if I do need to break confidentiality, is I would always have the conversation with SADI first to explain that I would need to report it and why, and that it was with the intention that it was actually about potentially looking at these improved supports and strategies about supporting SADI. Now, in that context, it's a natural transition to then go that, yes, the information we have with SADI is confidential, but in that context, we will be looking at what might be safe housing for SADI. And so you might be also assessing what is the situation with her family of origin or other family members, which might be safer alternatives for her. And if you deem that it is a safe situation with Sadie's consent, you may actually get Sadie's permission to actually get in contact and sometimes facilitate how to actually get in contact with people who might actually be supports for Sadie. But it is something which you do need to navigate carefully, because you do need to make sure that that is something which is also a safe process, bearing in mind that there may be reasons why Sadie left that situation in the first place. This probably would be something which, if you did need support and advice, where you might actually call out to an experienced supervisor. So that could be something where, you know, I'm very happy, and I think contacts might be there if you wanted to reach out, and we could have some further conversations about those processes for peer supervision and support. And case conference, I think the question is really, do you have an option to have discussions, which I think just goes on about peer supervision and support. I think that's what that question was about that. Yeah.
Beautiful. Thank you so much for articulating that, May.
Mm.
If we move to case study 2, we have a new family who have come to see us. So in this situation, you're working in a metropolitan area for a large medical clinic. There is increasing pressure to see as many patients as possible across each day, and you are working long hours. It's 4:30 p.m. and you're about to finish your consultation with Katie when she discloses being concerned about the relationship between her ex-partner and their 4-year-old son, Jack. Katie advised that her ex-partner had been stalking her for some time after the relationship ended, and contact between Jack and his father had only recently recommenced. Katie advised that since this time, Jack has started to wet the bed, has been crying and upset before handover. Katie further advised that when being taught protective behaviours at home-based daycare, Jack said, "Daddy is allowed to touch me everywhere." So in the context of this situation, Rachel, what first comes to mind in a legal consideration?
I think we planned for May to go first with this one. We're to switch it around a little bit. So I might hand over to May while I get some lights on in here.
Yeah. Look, I have to say, Jack's behaviour really sends off alarm bells for me. He really does need a formal assessment in this situation. And so this is where I would be calling my local specialist services, which might include a practitioner who does forensic assessment for children. So that could be a forensic psychologist or forensic psychiatrist. In my situation, I guess I have, a network of people who I do get in contact, but it could be that if you have, you may be able to work out who is your local forensic psychiatrist in your area or forensic psychologist in your area, or there is also the GP psychiatry line support that you could contact as well. But this would probably be a call for help. One. The practice would also have to have processes to ensure appropriate confidentiality, bearing in mind that Jack's father might request access to his son's medical records. So Katie will need her own support. And similarly, you have to be really careful about documentation in notes. Like if Katie writes things about herself, do not include those in Jack's notes. I sometimes do cues to myself and just say, Kate, accompanied by Katie, and see her notes. So her notes are in her notes, Jack's notes are in his notes. And it's just very careful about what you say, and any allegations that then Katie says about what's going on about Jack is allegations in Katie's notes, but you could certainly write that Katie has expressed some concern, see her notes. So I guess those might just be some strategies or tools about how you get around ensuring that there is appropriate documentation of which is going around, though you might need to then have some processes in case Jack is being seen by multiple providers. And sometimes there can be notes in there going, make sure that you contact so-and-so doctor if you see this person, just to make sure that there is some way that there is a communication, that there is concern about this child as well. And I would also be seeking advice from my medico-legal indemnity to flag this with them, that I have this concern, because they may also have some other specific advice about how you might document in that specific scenario. which I imagine Rachel will speak to afterwards as well. I'm mindful that there's a history of stalking, so it's unclear what the risk associated with this was. But it is important to consider the safety for Jack and Katie and any associated parties. Katie might actually be able to provide some guidance on how to safety plan, because she's had to navigate this in the past. And the fact that they have been able to re-establish contact means that they have had to have some process about how they navigated this. So be okay with leaning into the expertise that your patients bring to you as well. Separation and loss can be a significant trigger for aggression or violence. So these are potentially going to be unavoidable conversations in terms of how to manage potentially access of Jack to the father. So you might need to also plan how to navigate those sort of conversations with navigating the risk as part of reducing risk. But it can be a really delicate and tricky situation, because it may be that there might be some there might be some orders in place about what contact that the father may have with Jack. I might let Rachel speak to that a little bit later, but it is going to be something just to be conscious about, because it comes into your safety planning in terms of if there is going to be at some point a reduction in contact, that you may need to add that into your safety plan. I know that in these circumstances, you are the general practitioner, you'll be facilitating assessment and care, you are discussing the safety plan with Katie and Jack and being conscious about what the risk is for them. Usually in these circumstances, the risk is usually in the context of the parent and child and the person that you have to care for. You are not the investigator determining whether Jack's father will continue to have access to his child, or the medium for the loss of the relationship. So I would really encourage you to work together in the process with DV services, child protection, your forensic experts, and this ensures that you are supported in the decision-making processes, but not responsible for that, which also really helps in the risk mitigation at a number of different levels for you as well. But I do recognise that this is really emotionally triggering work. A good team helps to support that. Some practices might have some internalised structures which allow collegial discussion or psychological mentoring, or you might want to reach out externally. And as I keep giving a plug for, there's the Specific Interest group, which you can reach out to, or you can arrange your own professional supervision as well. But there is peer group supervision also available through the college as well. So I'm really going to acknowledge here that the system isn't perfect. There's a lot that can still be improved regarding access to expert services and support. And I imagine some of you were listening into what I was saying, going, how the hell do I access, sorry, I should not swear, but how should I access some of these specialised services? And I guess that is something which on a case-to-case regional basis is part of how you build up your support networks and discussion, but at least knowing those would be the categories of what kind of team members you would be looking to reach out for. And there's also very little within the system about what you might do if you were also the GP looking after Jack's dad. But I would recommend not having care for both parties. That certainly in this circumstance, it would really be very ill-advised to be doing that. And here's my plug for research and advocacy in this space about the fact that I want to validate and acknowledge the challenges in the system, but also recognise this could be a space where we actually reach out to say we need more support in these systems. And you're not alone in this. There are still some avenues to reach out, even if you do have a complex case like this.
Thanks, May. We might hand over to you now, Rachel, for the legal context.
Yeah, so this is a really tricky, practice situation, but it's also a really tricky legal situation. So first you would start, similar to the first case study, you'd start looking at whether what you've been told gives a reasonable belief that sexual abuse has occurred or is likely to have occurred. Like I said, that's pretty much the consistent across everywhere, across all jurisdictions. This isn't a straightforward disclosure. We've got a variety of behavioural changes in Jack, which may on one hand be a natural reaction to adjusting to seeing his father again, but may on the other hand be something far more sinister. Sleep disturbance and wetting the bed is a common stress reaction where a family separates and there's conflict going on. As a former family lawyer, I'd say that this was certainly something that a lot of my clients would talk to me about with their children, and in a lot of cases it would then calm down once there was a routine established. But it's the statement that daddy can touch me anywhere that raises a red flag that there might be sexual abuse here. I would ask Katie whether there's any other behavioural changes in Jack that she's noticed. And then, of course, you'd factor those into your decision making. Just a recap from the last webinar. So you keep in mind that the reasonable part of this threshold is what's a reasonable belief to someone with your skills and experience. You might be very skilled at working with children who've exhibited behavioural changes as a result of child sexual abuse, or you may never come across this in your practice. So you're not expected to know everything, and that's where we come into May talking about reaching out and speaking to people. Also remember that it's not your job to decide whether sexual abuse has happened. Your job under the mandatory reporting the considerations is whether there's enough of a risk here that you should let authorities know so that they investigate and make conclusions. And yeah, you're not that decision maker. This is a borderline one, but I would say without any further information, I don't think there's enough information here to definitively say that you must report under the mandatory reporting legislation. But it shouldn't end there by any means. That's not the end, and May has spoken to other steps that can be taken. From a legal perspective, it's really important that Katie gets some legal advice about the family law part of this, and she may well have, given that the contact with the child has started again, they might have orders in place, they might have gone to mediation and have an informal agreement, but you'd be wanting to check in about this. I would note that allegations of sexual abuse by a parent in a relationship separation situation are really fraught. They can be weaponised in court and turned against a primary carer with allegations of parental alienation, if anyone's heard of that. And it's a real thing. I've seen it play out in family courts. And I don't say this to minimise the seriousness of the allegations at all or your concerns. But if there's ambiguity about what has happened to a child and you actually do get to the conclusion that this doesn't trigger a mandatory report, I think it's really important that Katie can speak to an experienced family lawyer to know what the next steps might be. And it may be that when that is offered up or you get the extra information from another specialist, that you change your mind about whether you should be reporting. There might be more information that comes forward. But an experienced family lawyer will be able to give that careful advice on what to avoid to Katie, not to you, of course, but what not to do and what to do. And it will no doubt involve further contact with Jack and his GP. So a forensic examination might be appropriate. I'm not saying that it may launch straight into a forensic examination, but it may be appropriate. But we've got complicating factors that the father will have the right to access the child's medical file. But there's another complicating factor, which is that depending on what informal or formal arrangements are in place, there may be a necessity for the father to give consent to any further medical treatment of a child. And that will depend on what's been done in a legal sense. So that sort of complicates things further. I would say, though, that if there's an urgency and there's a real immediate risk to Jack, then that requirement to get his consent would be overridden. But again, a good family lawyer is going to be able to give you careful advice on how to move through that. Give Katie careful advice anyway. Because of the complexity, May's comments on confidentiality and the record keeping is really important, because it could affect any family law proceedings down the track. And I absolutely endorse what you said, May, about the separation of those notes and the importance of that. In terms of Katie seeing a lawyer, if she doesn't know one, then the starting point, in my opinion, should always be a referral to a women's legal service. There's one in every state and territory. They're a really good starting point to give some general advice and then provide referrals to other lawyers or legal aid if necessary. It's really expensive to get legal advice, but women's legal services will give people that starting point so that at least they know what their options are, and they've got a few referrals up their sleeve as to what their options might be. I'd also note that following that stalking and even the nature of the him saying that he can touch Jack anywhere over his body, which to me talks about control and ownership. It raises red flags about coercive control and domestic violence generally, and it may be that Katie really needs some advice about that, and whether there's any avenues she can explore in terms of getting any legal protection, like protection orders or intervention orders, in place straight away for herself and potentially for Jack. Again, a complex legal area, but one that I think that Katie should be exploring in this situation. So as a lawyer, we often do this. We say it depends and there's no answer, but I hope that gives a little bit of context around the things that from a legal perspective you'd be wanting to look at in this circumstance.
Thank you, Rachel, and thank you, May, as well.
Do you mind if I just make a comment to this as well, if that's okay?
Absolutely.
I just reflect that I just want to point out that the challenge that we have in this circumstance is the ambiguity. There's enough for us to be a concern, but not enough that there can be immediate action in terms of separation. And I would comment on the moral injury that poses for the general practitioner about sometimes feeling impotent in that circumstance. There was a question in here about why we might speak to a lawyer rather than child protection. You were actually speaking to both at the same time because of how complex this circumstance is, because there can sometimes be a bit of watching and waiting before you can actually make decisions about what your action is going to be. And so the expert advice in each of those arenas actually assists regardless of what your outcomes are going to be, because you'll need child protection expertise, but you'll also need legal expertise as well. And I'm also going to point out that in the time as a general practitioner, as you're waiting for that process, you can continue to still support Katie and Jack in this process. It's still going to be protective. Jack is 4, so you can certainly have those conversations about having a mitigating influence, regardless of what's happening about actually, even though Jack might be getting some unhelpful messages and we are concerned about his safety in the situation of the father, the fact that hopefully you may have a more protective parent who gives some other advice, and at age of 4, there can be some processes that a 4-year-old can start to actually piece together, that some situations, these things can happen, but in a different context, I am hopefully safer. And I think we just need to be mindful that is what we can help support, even whilst we're not quite sure about whether separation is going to be happening in this circumstance.
And if I could just chime in there to the question that's there now. So I think you need to speak to both. If Katie is going to speak to child protection, then she'll get a way forward from them, hopefully. But The reason that you'd also want to speak to a lawyer is that this is going to, something more needs to be done in terms of what contact Jack's going to have with his father in the future. I think that a lawyer would also be able to talk to Katie about what is, when she should be reporting to child safety, if that's what she chooses to do, new concerns. Because like I said about the weaponising in court, I've certainly seen it turned against women who make reports or get other people to make reports, and the frequency of those reports, which is almost always prompted by concern, extreme concern for their child, has been turned against them. And that's what I guess I was getting at when I said that an experienced family lawyer will be able to give careful advice on how to move forward.
Wonderful. Thank you both. I know I'm just conscious of time, so we might move to the next slide if that's okay. We did just want to pause after going through these case studies and some of the discussion and broadly in consideration of the work that you've already done and are likely yet to do surrounding child sexual abuse. This work is so important. Your well-being within that is also really important. And to be able to show up in consultations across your day, across the week, whilst holding that emotional space, not only for potentially adults and children, but also yourself, can be really challenging and absolutely exhausting. We know that the way that people look after their well-being is really personal, and many of you will already be very well skilled in managing this. But there might be times where those things don't work anymore, or they're not as helpful when you're navigating some of those challenging situations, or you might even be supporting someone else, maybe a colleague. So we've heard a bit around the specific interest group tonight. There is information, the white book surrounding support options. There's also information that you'll receive following this webinar around other support services. Really would encourage you to access those as well if you feel that they would be helpful. And finally, just we're so grateful for you joining us with this webinar and giving your time to thinking around how can we respond in better, safer, more supportive ways to child sexual abuse. There is absolutely so much more work to do in terms of how we identify and respond, and we can't do it without you. So huge thank you for joining us, and I will hand back over to Jovi.
And as you may, would you like me to launch the second poll?
And while you're responding to that poll, just a reminder of some of the resources which we've shared before. Just for those of you listening in, just a reminder, if you do need to reach out, there's also, Doctors for Doctors that provide support specifically to GPs, particularly if you are feeling really uncomfortable after listening and reflecting on what we've discussed here tonight. And you may also find some resources through Blue Knot, Beyond Blue, and Information and Health Pathways as well. So. Oh, good. I'm glad to see that people found that they're feeling more comfortable in this area. I might move us on to the next question, if that's okay. So this is, again, where we want to be pragmatic. Now that we've had a bit of a think about kind of pragmatically what we might do, what's one thing you think that might help you in your decision-making around mandatory reporting? Be a policy. I feel like some of the things which come up on here might resonate with all of us here, but yes, I'm a great believer in advocacy for systemic change and structural change. I'm not quite sure, whoever put in the comment about organising, is there a comment about the meaning of that? It might be that it might have been a string of words together. So Jovi has put in the chat, Stacey has put in the chat how to access the first webinar, which also includes resources for guidelines in specific states and mandatory reporting. So this webinar is a follow-on where previously we've already actually provided some of that information as well. I'm just conscious of time, so we might have to just move on to the close. So Jovi, I might leave that. If there's any other questions that come up following all of this, or Oh, sorry, what's the join at? But if there's any other further questions, then please get in contact. But look, thank you everyone for your participation and really active engagement tonight. I've really appreciated all of the engagement, and I hope this was helpful. And thank you to my co-presenters, Stacey and Rachel. It's been really meaningful. We realised when we were doing this that this is an area that all of us do find really challenging. And I think that the discussions here really reflect that tonight, but that, you know, this is a shared experience, and we hope that together that can at least be empowering together.
Perfect. Thanks so much, May. I'd also like to extend my thanks to Stacey and Rachel, and of course everyone that's joined us online this evening. We hope you found value in tonight's session. So again, a copy of tonight's presentation will be sent to everyone tomorrow morning, along with a link to the recording. And lastly, if you've got a couple of minutes to spare, if you would really appreciate it if you could please complete the survey and provide your feedback following this webinar. That's all we've got time for this evening. Thank you and good night.